give the forum to our keynote speaker, who's Professor Senait Fisseha. I think the audience here is very familiar with her. She's been involved in the healthcare ecosystem of Ethiopia for a very long time. She has worked with people to people in Hapa before that, and from her days in the University of Michigan, and then now with the Buffett Institution, she's been involved in a lot of initiatives. So it's a real pleasure to have her here. So the floor is yours, Senait.
Thank you very much. Can you hear me? I hope you can hear me. Great. Good afternoon. It's wonderful to see all of you virtually. I'm sorry I couldn't be with you in person. And I'm really sorry I couldn't join at the opening. But unfortunately, you know, the timing didn't work. It was 2 a.m. in the United States. But I'm really glad to be able to join now. And I'm also really happy to see this conversation on women's health with a focus on obstetrical care, fertility, breast cancer, cervical cancer. So I really, really wish I was there for the morning. But I think I caught the last panel around accreditation and quality of care. But what I'm going to do as we gather here today is really sort of pull us up and look at the status of women and women's health globally, not necessarily in Ethiopia, but why are we doing what we're doing in our little microcosm, and how does it add to the collective? I really feel it's imperative that we reflect on the evolving landscape of women's health in the 21st century, as the title says, particularly in the realm of reproductive and maternal health. This era presents both unprecedented opportunities and complex challenges that demands our utmost dedication and innovation to ensure well-being of women everywhere. As I see on the screen, I see very few women in the room, which is sort of unfortunate reality of leadership and medical education in sub-Saharan Africa. You may have seen the mantra, there's no us without us. So in a lot of places, women are demanding that they are part of the discourse when we talk about their health and well-being. But having said that, let us begin by acknowledging the progress we've made over the last 30 years. You know, you look at the MDGs up to 2015, and then the Sustainable Development Goals that have about 6 years left. There have been a lot of advances in maternal and women's health broadly. Advances in medical technology have really revolutionized reproductive health care, offering women greater control over their fertility, more options for family planning, improved outcome for maternal and infant health, from contraception to assisted reproductive technology, which I have the immense joy of having set up the first IVF program in Ethiopia. I think we have empowered women to make informed choices about their bodies and their future. We have seen significant reduction in maternal mortality in Ethiopia, although we still have significant progress to make. Yet, amidst this progress, disparities persist globally. Socioeconomic factors, cultural norms, if you take our country, early marriage, female genital mutilation, and systemic barriers, you know, being born in a poor family in a rural part of the country, just continue to limit access to essential reproductive and maternal health services, disproportionately affecting marginalized and poor communities. So as healthcare providers, I really fundamentally believe it's our duty to address these inequities head on, ensuring that every woman, regardless of background or circumstance, receives the care she deserves. Furthermore, in the 21st century has brought new challenges to the forefront. I mean, we're looking at climate change, environmental toxins. I have seen the topic of infertility this morning. We are seeing from plastics, like toxins that are disrupting the HPA, hypothalamic pituitary adrenal axis, increasing infertility. We're seeing a massive shift in demographic pose that unique threats to women's reproductive health, necessitating a key interdisciplinary collaboration and proactive measures that will safeguard generations. So if you look at health inequity, for example, between or within countries, they really pose the greatest threat to universal access to maternal and reproductive health services. For example, maternal mortality shows the wide gaps between rich and poor nations. Overall, developing countries account for 99% of annual maternal deaths in the world, out of which 70%, according to the WHO 2019 report, is in sub-Saharan Africa. And I don't know how many of you are in women's health, but the annual World Population Report by the UNFPA was just released a couple of weeks ago. And you can see that, women with complications of pregnancy and childbirth in African region are 130 times more likely to die than women in Europe and North Africa. And inequities within country and within regions, even within the same country, are immense. If you look at Ethiopia, a pregnancy outcome for a woman in Addis is very different from that of a woman in Omo region or in Gambella, right? So in the same way, the report mentioned, for example, in Madagascar, women from rich communities in the cities are more likely to receive skilled birth assistance than poor women when giving birth. And across the Americas, including the United States, people of African descent are more likely to experience obstetric complications. The same, as women in rural Ethiopia. So I think the work you are undertaking by expanding quality training is going to ensure access to all, right? I mean, the goal is how do we not leave, some people behind? If you look at, I saw on the agenda, there was conversation about HPV and cervical cancer. There are forces beyond us, like there are structural malfunctions and global health decisions that have ramifications for the work we do at the local level. There are several epidemiological studies on the distribution of human papillomavirus genotype, for example, that have demonstrated that the 3 existing HPV vaccines do not cover, for example, genotype 35, that is relatively common among women living in sub-Saharan Africa. This was data that was published by Dr. Siyum in Ethiopia. So this non-vaccine HPV infections could be responsible for the higher age-standardized incidence of cervical cancer in Africa. Low-income countries where HPV vaccine has higher health impact in reducing cervical cancer burden have significantly lower vaccination coverage. For example, HPV vaccination of 1,000 adolescent girls prevents on average 34 cervical cancer deaths in Gambia, but the vaccination coverage is low at 5%, in contrast to Italy, where the vaccination coverage is 60% with 2 deaths prevented. We also saw that during the COVID pandemic, it really starkly highlighted the global health inequities among nations, exacerbating disparities in access to healthcare, including maternal and reproductive healthcare. In many low and middle income countries, healthcare systems have been overwhelmed by the pandemic. It's just amazing when you talk to Africans, the narrative you hear is how fewer people died in Africa during COVID. The data says to the contrary, and unfortunately, the disproportionate burden were not in the elderly like we were seeing in the United States, because our population is quite young. A lot of the death we saw was because essential services like maternal service were disrupted. And broadly, it was estimated globally there were around 12 million women who, for example, cannot access contraceptive services, basic, which has resulted in over 1.4 million unintended pregnancies. Global and maternal and fetal outcome also have worsened significantly during the COVID-19 pandemic, with an increase in maternal death, stillbirth, seeing a rise in ruptured ectopics, unsafe abortion, really, exacerbating an already weak health system. So for me, it's extremely important that when we think about training and academic institutions, we have to think beyond the silo of just training fewer providers, but rather lifting our heads up and saying, how are the trainings we're doing ultimately driving impact at a national and subnational level? How does training doctors ultimately improves the ability of nurses and midwives, community health workers to provide quality care? In a country like Ethiopia, it's going to take us another 100 years or so, unless we dramatically scale up our workforce training to be able to meet the minimum requirement for the WHO. And for a number of factors due to our inability to pay, retain, avail postgraduate opportunities in the rural areas, most providers tend to be concentrated in the city. So I think as stewards of public health, we really must remain vigilant in our efforts to mitigate these risks and advocate for policies that prioritize not only the training, but retention of workforce, adequate distribution of workforce throughout the country, not just concentration of workforce in big cities. So, in light of these realities, I really urge you to double your commitment to excellence in patient care, research, and advocacy like you're doing. Stay informed of not just driving our decisions. I mean, as the moderator was speaking, I had spent over 10, 15 years, working at St. Paul, and I take immense pride to seeing how St. Paul had transformed. But one of the things we really tried to do was how do we use our residents and fellows and medical students to push out, right, our providers to go and be distributed from Ambo to Arabe to really take quality care to communities. And if we really want quality women's health care, that's going to not only just talking about reducing or preventing maternal mortality, women should not die giving birth. The conversation should be, how do we help women attain quality life and well-being so that they thrive and they take care of their families and they contribute to the economy, and like the few women in the room and myself have the capacity to self-actualize, to finish school, to be leaders, right? And this is going to require us addressing interconnected issues of physical, emotional, and social factors. This means integrating mental health support to reproductive health care. It means addressing the impact of trauma and violence on women's health and outcome, and promoting comprehensive sexuality education, expanding access to contraceptive services so that not just focusing on curative services, but on preventive services so that a child has the opportunity, even if she, we are trying to tackle early marriage, but a lot of young girls in the rural area get married early. If they get married early, how do we ensure we not only put policies to dismantle early marriage, but they have access to contraception? How do we make sure they stay in school and that they are supported to finish their school? So I think as we look at these things in individuality, kind of lifting our heads up and looking at the factors in society that hold women back is extremely, extremely important. So I think maybe I will summarize, and in closing, I will say, let us remember that our work extends, far beyond the classroom, far beyond the doctors and nurses we train, and far beyond the walls that just confine us. So it's really, for me, it's a calling, it's a responsibility and a privilege to do what I do. I know it's the same for all of you in the room. It requires unwavering commitment to the health and dignity of women everywhere. I am enormously proud of P2P. I've been a founding member 25 years ago when I was a medical student. So I'm really grateful for the dedication, the expertise that you bring, and your tireless efforts in advancing the health and well-being of Ethiopians across the country. And I'm just particularly pleased to see this focus on women's health, and together let us just continue to strive for a future where every woman can live a life of health, autonomy, fulfillment, and dignity. So thank you so much for giving me the opportunity to reflect, and I really, really wish you a very successful convening for the remaining of your time in Addis. Thank you.